Well, I am happy to welcome you all to our May Talks on Tuesday, Early Intervention and Feeding, When to Seek a Specialist, Part 2. We are delighted. This is part 2 of the one that we did in April. And I'm going to ask Stephanie if you'll switch to the next slide, please. I'm delighted to welcome also Stephanie Shrewsbury, who is a service coordinator, and Jessica Hale, developmental service provider from the Virginia Beach area. And I am going to turn it over to them. So thank you guys, and thank you for joining us.
All right, just a reminder to have your handouts near that were sent to you prior to the webinar. Jeannie will also be dropping a link in the chat if you still need access to those. There should be 3 separate handouts. One of them is just our resource slide. Okay, and then last month, Kim shared with you typical and atypical feeding behaviors from birth to age 3 and several examples of children with atypical feeding that did not need a feeding specialist. If you missed last month's Talks on Tuesday, you can watch the archive, which will be linked in the chat. Okay, welcome again. My name is Stephanie Shrewsbury, and I am a service coordinator with the Virginia Beach Infant Program and have been in this position for 10 years now. Over the past decade, I have gained so much knowledge on overall child development and feeding concerns, which we will be talking about today. Jessica and I are so glad that you're here to chat with us about early intervention and feeding. Through the first portion of this presentation, you will mostly hear from me from a service coordinator's role and perspective when it comes to a child with feeding concerns. So let's go ahead and dive right in. So the main thing I want to discuss are some ways you can help gather as much information as you can as a service coordinator regarding a feeding concern. If you are the first person to meet with the family, you play a crucial role in gathering as much detailed information as you can. And I know I keep saying service coordinator, but this is just not for the service coordinators out there. This is for any provider who may be in the home and the family expresses concerns with their child's feeding. So first, some families do not want to change feeding behaviors, or they may not even realize that it is a concern. Jessica is going to be able to provide you with more information on some atypical developmental behaviors and expectations. And if you watched Kim's Talks on Tuesday last month, you saw some examples of typical and atypical feeding as well. If you do not feel comfortable explaining these behaviors to a family, ask the feeding specialist in your area. To piggyback off of what Kim said last month when she said no feeding therapy is better than bad feeding therapy, you will hear me say no feeding suggestion is better than a bad feeding suggestion. So let's talk about the basics and getting as much information as you can when a child is referred to early intervention with a feeding concern. Most of the ages and stages questionnaires that are sent out to families have questions regarding feeding. For example, the 14-month ASQ asks if your child can pick up small pieces of food with a pincer grasp. This is a great opportunity to ask what kinds of food if the parent checked yes. If the parent said no, you could also ask them if they have ever given their child the opportunity to pick up smaller pieces of food and what does that look like if they have. One of the other screenings is the social emotional tool that can provide some basic questions about feeding as well. Some localities may have a separate family questionnaire that can provide more information on the feeding concerns that are sent off to families prior to the initial intake. And as you go along and get more experience as a service coordinator or a provider in the home, you can always make your own list of questions to ask the family as well. All right, so let's go ahead and chat. You arrive to a home for an intake where the mother informs you that she has concerns with her daughter's feeding. What are some of the questions you would ask the mother after she tells you this? So I'm going to give everyone a little bit of time, but just type your response in the chat box. And once again, the question is, what are some of the questions you would ask the mother after she tells you that she has concerns with her daughter's feeding? Yes, what does a typical meal look like? That's a great one to start off with. What does she eat? What are your concerns? Where does she eat? Yes, that's awesome. And what does it look like if it's going well? Eating together as a family. Yes, all wonderful questions. How much as well? That's a great one too. Wonderful. Seems like you guys have some experience with this. Okay, so moving on to the handout that we sent you guys, which says examples of questions to screen and assess feeding related problems in practice. So we're going to chat again. If you had a chance to look this over, my question is, what are some of the questions you see that you wouldn't have thought to ask? So I'll give everyone a little bit of time to drop your answer in the chat box, but what are some of the questions you see that you wouldn't have thought to ask? So I know the one that when I saw this was, how do you prepare the food and liquids you give to him or her? And that kind of segues me into, is your child only eating from pouches? That is very important information to give your team. Are there any feeding battles? Yes. And what is the parent's response when the child refuses? Yes, that's a great one. If they're getting frustrated or if they stay calm. The fear and depression surrounding meal times. Is the child still breastfeeding? Yes. Does it look different at daycare? What a great question. Yes. And most of the time we hear, yes, it does look different. Or in other settings, such as restaurants, or if they're having a picnic at the park. Yes, wonderful. And I hope that you guys can take this resource page and maybe take some of these questions to develop your own little list as well. Okay, so over the past couple of months, I know we have all had to shift our normal routines with work and get a little outside of our comfort zone. So here we have an intake that was completed via Zoom with a service coordinator, dad, and his son. Dad has some concerns with his son's feeding, so we are going to watch 3 short clips and reflect on the questions that were asked by the service coordinator.
Okay, so let's start by chatting about some of the meal times with Mac.
Yeah, sure.
Tell me, Dad, what does mealtime usually look like for your family?
What does it look like? Can you tell me a little bit more about that question? What exactly do you mean?
So is this usually, like, is he usually eating at the table with you guys? Do you eat together at the same time?
Yeah, that's something we try to prioritize, make sure that we're always sitting down together as a family, eating with everybody.
And it looks like whatever he's eating right now, he's really enjoying. What kind of food does he typically eat?
Yeah. So he's pretty much. He's a pretty good eater. Eats about what we eat within what's appropriate for him, of course. So right now he's got kind of some oatmeal, pancakes, a little bit of like a quinoa salad. We don't eat a lot of meat in our house. Occasionally a little bit of fish, and he'll enjoy that.
And I see that he's doing some really nice finger feeding. Is that typically how he feeds himself? Do you see him using utensils?
Yeah, we've introduced some utensils, back pretty early. He's now 14 months or so, and back even 7, 8 months, we kind of load up his food for him and let him, kind of hand over hand, let him bring it to the mouth. He's very interested in the utensils. He sees mom and dad using utensils, so we definitely use a spoon, and he does an okay job loading it with a little bit of help. Once it's loaded, he can certainly bring it to his mouth pretty well. And then the fork, we started playing around with stuff to stack the food. He enjoys that. So yeah, a little bit of utensils, but it's more for exposure than it is actual success feeding.
So this is our new normal. This is how most of our intakes are being completed, or even all of our sessions. So I want to talk about the first question she asked is, what does mealtime look like for your family? This is an awesome opening question to get the conversation started on this family's feeding concerns. For the second question, she was able to observe that whatever the child was eating, he seemed to be enjoying, which then she asked, what kinds of foods does he typically eat? And then the last question, she was able to observe that he was finger feeding himself, which led her to ask if he is using utensils and how he typically feeds himself. I think the service coordinator did a wonderful job asking open-ended questions to the father, and also not only after interacting with dad, but with the child as well. You can see the power of these questions too with dad's detailed responses.
And I see that he's doing some really nice. Okay, so.
Okay. So I noticed that you like to keep him clean. Have you ever let him explore his foods on his own and get a little messy? We all have those parents who are terrified for the child to get messy and play during meal times. Do you have a family that is constantly cleaning the high chair or the child's mouth? We can encourage the family to have the child explore their foods and get messy. This might make the family anxious at first, but you can suggest items such as a cheap shower curtain from the dollar store to place under the high chair, or a long sleeve bib to help with cleanup. Once again, you have to ask the family if this is something that they would like to explore and work on. So the next thing I hear frequently is, well, he or she prefers to graze and never sits down and eats a full meal. Ask the family if they've ever experimented with timed meals where the child sits in their high chair for breakfast, lunch, and dinner, or wherever the family eats. Are they in daycare? Has the daycare facility or provider tried this as well? And to piggyback off of what somebody answered earlier is, what do daycare feedings look like? That is very important to know if it is super different there from what it looks like at home as well. And then acknowledging the fact that not all families are able to sit down for meals every day because of careers, after school activities for older children, etc. And as Kim mentioned in part 1, some families prefer to eat dinner on the couch or on the floor of the living room, and that is totally okay. And then one of the last things that I hear frequently is, oh, we have never given him a utensil before. Encourage them to have their child explore with child-safe utensils. As the parent, you can show them how you eat with utensils as well and model for them. And as stated in the previous slide, it will get messy, but let them explore and play. And once again, as we saw in part 1, some cultures don't even introduce utensils until they are 3 or 4 years old. So you have to ask if this is a priority for them, which we will see in the next slide. And then if they mark no on their questionnaires regarding utensils, this is such a great segue to dig deeper and suggest beginning to explore with them. So if you came last month, you saw the video of the little girl being fed by her grandmother. So I'm just going to play this short little clip again for those who missed it. So as you see, the grandmother is using a very large spoon and holds a napkin under her chin the whole time. This was something that Kim mentioned, that they, in their culture, they do not give them utensils until they are around 4 or 5, and they keep them very clean. So Kim had to ask further questions to know that, no, they don't want to change the way that they're feeding her at this time, because that's just not their culture. So let's discuss. Would you share an example about a situation you have had regarding a cultural difference in feeding or any other concerns? So anything that you've walked into a house and you've kind of had to shift your mind frame and know, okay, this isn't how I would do it, but this is how their culture does it. So I'll give everyone a little bit of time to place their response in the chat. And once again, just an example about a situation you have had regarding a cultural difference. Waking. Eating on the floor or sofa. Yes, exactly. Extended breastfeeding, which can impact eating solids, absolutely. In the Kurdish family, where dad served, all family members using his hands. The whole family grazes, so the child eats that way as well, yes. And the parent feeding the child until they're around 3 or 4 years old, exactly, just like this video. And then Middle Eastern families use their hands, yep. And another good question too to ask is, what resources does the family have to obtain food? I have worked with many families who get most of their food through WIC. So you can ask the family if they have the option to pick out the foods and suggest getting different ones each time so the child can try a variety of different foods and textures. Okay, so I hope this information can assist you all in gathering as much as you can during your first visit or your normal visits if you are a provider in the home as well. This helps our teams in determining eligibility or being able to have a good understanding of where the child is in relation to their feeding concerns before even stepping foot into the home for the assessment. Always remember, meet the family where they are, not what you or the team think is right. And when it comes to feeding, you should always encourage the family to discuss any concerns with their pediatrician first. And remember, no feeding suggestion is better than a bad feeding suggestion. Jessica will now share more information on what exactly is the concern.
All right. Hi, everyone. My name is Jessica Hale, and I'm a developmental service provider in the city of Virginia Beach with Stephanie and Kim. And I have been working here for a little over 3 years now and learned so much about feeding through the fortunate pairings that I had in assessments with great speech therapists and Kim Geisinger, a feeding specialist. So today, I'm just really going to keep the ball rolling with the discussion of how providers can use all of this really great, robust information gathered through questioning, help determine what ultimately might be underlying a parent's concern. And we all know that this is so important to gather as much information as possible about a family's developmental worry, because ultimately that's what aids us in determining the most appropriate and effective treatment that we can offer in early intervention. So Stephanie, Kim, and I all sat down together and we reflected on our collective experience in early intervention as a developmental provider, a service coordinator, and a feeding specialist. And we developed a list of 4 umbrella challenges that we feel we see most often in early intervention. So as we go through these 4 challenges today, our hope is that you guys will get involved, give us your input so that we can learn from each other and reflect on the issues that we're seeing across the state and even out of the state. I know we have some people in West Virginia and North Carolina today, possibly even more, so that we can see kind of how we can help each other through this process. I want to give a quick disclaimer first before we get into these 4 umbrella challenges. And we want to acknowledge that even though we're talking about these 4 challenges separately, we often see that multiple feeding concerns can exist concurrently. So we know that we're often going into assessments or into homes for service implementation, and we find that we're giving strategies for a wide spectrum of issues and perhaps multiple challenges that we're going to talk about today. So these 4 concern categories don't always separate themselves so neatly for therapists and for the families that we're working with. And there are also situations where one feeding concern can ultimately cause 1 or more additional concerns. So we are in this very fortunate position as early interventionalists to sometimes prevent the compounding of issues. So if we can get in that house and identify one feeding challenge and really provide assistance with that, we could really help that child and the family long term. So the first challenge that we're going to talk about today is our sensory feeding challenge. So this type of concern affects how a child reacts to the taste, texture, temperature, smell, and or appearance of a food or a drink. This, unfortunately, can lead to aversions to age-appropriate or the nutritionally valuable foods that families want their kids to access, and it can lead to really strong preferences for a very limited diet. So we're going to take a second. We love to hear from you guys here in the chat. What are some examples in your practice that you've seen of sensory-related concerns? So again, when you're going into a home, what are some things that you see that you feel are sensory challenges? Great. Only eating crunchy foods. A couple of you said you're seeing that. Gagging at the smell of food. Absolutely. Only soft foods, only tolerating purees. So definitely having texture preferences, noticing a lot of you saying, you know, mushy ones. Excellent. Not wanting to touch certain foods. Great, Jen. Not liking even the color of certain things or having a preference for only certain colors. Right, Lindsay, excellent. Not liking food on their hands. Yeah, Tiffany, aversion to all solid foods. So they only want those baby foods or they want to continue to be bottle fed. Excellent, you guys. Only liking hot and spicy foods. So these are wonderful examples. You guys touched on the appearance, the texture for sure. We got a lot of I enjoy that a lot of you noted that sometimes we see gagging not just when certain textures go in their mouth, but just looking at certain foods or even touching certain foods can sometimes cause that aversion. Here, along with spicy hot foods, if there's a sensory concern, we might also see overstuffing of the mouth. So they need more of that sensory input to feel what's in their mouth. Absolutely. These are all excellent examples of sensory concerns that we see in the homes. So let's talk about some tools that we can use. So if we go into the home and we're seeing a sensory challenge, I'm sure you guys have a ton of tools, but if you could check out your handout on our toolbox tips, the information you see listed on your screen is also on that handout. If you guys could use your stamp feature that Corey went over, so if you go to that annotate feature with the stamp, and go ahead and drop a stamp for me on a strategy that you see that you have used in your practice with some success. Excellent. Looks like a lot of people have tried messy play, getting them in there, getting them to play with those different textures. Excellent. Lots of repetition. So I'm noticing that only one person so far has noted that they've tried a no thank you spot. So let me delve into that one a little bit further so maybe it can become a strategy more people are utilizing. So a no thank you spot is what I call the place on the tray. Sometimes it's just a spot on the tray. Sometimes it's a separate bowl. Sometimes it's a plate that's on the tray or the table where kids can put foods that they're not interested in eating. So ultimately, the way that this helps is mom can prepare or dad can prepare his meal the way that he wants to. They can present the food that they want during mealtime. So that's giving a parent that renewed sense of control over mealtime, which we know sometimes they're lacking when we have this sensory challenge. And we're also giving the child control by saying, look, it's going to be on your tray, but you don't have to put it in your mouth. You don't have to eat it. But this is doubly beneficial because not only are we giving control back to parents and children, by putting something on a child's tray repeatedly, they're getting to see that multiple times. And not only that, but picking that piece of food up to move it into the bowl gives them exposure to the texture. So that even though they might not want to eat that food right away, we're still giving them the opportunity to get used to the texture and the appearance of food, so they might become comfortable enough over time to eventually bring that food to their mouth. So we're going to move on to our second challenge of the day, and that is our behavioral challenge. So another concern that we see is behavior-based, where a child or even a parent's actions is what's interfering with a parent's idea of an ideal mealtime. So we're going to watch a short video, and while we're watching it, I want you guys to reflect on some of the behaviors that you're seeing that you feel like might be impacting mealtime. So this is London, and London's mom has expressed that she's struggling with some behaviors at mealtime. So let's see. We're going to ask you to chat afterward about what you noticed.
London. London. London, May. Please don't throw it.
All right, so in the chat box, what behaviors do you see in this video that London is exhibiting, or maybe mom, if some of you guys observe that, that you feel like might be impacting mealtime here? Absolutely, testing boundaries. Great, Vicki. So mom's calling her name, and this might be a unique situation because she was trying to get it on video, but she's not stopping her from throwing the food, right? So mom might be reinforcing that. Absolutely. So lots of attention seeking you guys are observing. Yeah, great. And I don't know if you could see in your video, London is even looking up toward her mom after she throws the food. She'll look up. Great, T. Brister. So not sitting with other behavior models. So she's by herself. She might be seeking that attention because she's alone. Right, great observations, you guys. So let's chat again about some tools that we could use. So for our behavioral challenge, we're looking at just 3 tools of a mealtime schedule, active participation, and praise. So go ahead and use your stamp tool again and drop a stamp for me on the strategies you feel like you've used for behavioral interventions during mealtime. Right, lots of you do active participation, lots of praise. Excellent. So yeah, T. Brister noted that we can ignore behaviors, and that goes along with praise. So in that situation, we want to really offer a lot of positive reinforcement for good behaviors. And that also includes ignoring some of those negative behaviors, which you guys can probably attest to. It can be really hard for parents who want to control the behavior around mealtime. It's hard for them to ignore the things that they don't want to see. So when we're looking at a strategy of praise, we absolutely want to encourage children to seek that positive attention rather than the negative attention that they might be getting for doing something like London did with throwing that food and telling her little marshmallows bye every time she did it. Great. So our third challenge today is going to be our oral motor challenge. So oral motor skills refer to our ability to use appropriate oral strength and coordination. And if we have oral motor weaknesses when we're in an assessment or treating, that can really inhibit a child from accessing the foods that parents might like them to eat. This also affects the child's ability to eat the foods that they want to eat. So even though they are really interested in the food in front of them, they can't quite access it. So in the chat box, could you guys tell me what are some symptoms of oral motor issues that you have seen in the children that you work with? So again, if you go into a home and you see something, what tells you that an oral motor issue might be at play? Great, Karen. So overstuffing, we talked about that with sensory, but it could be overstuffing because of that low tone. Absolutely. Andrea, pushing the food into their cheeks, excessive drooling, Amanda, excellent. Vicky, so sucking on food, swallowing with the lack of chewing. Absolutely. Great, not opening their mouth enough. You guys have a lot of feedback on this one. Great, the tongue rather than the lips to form an oral seal around a straw. Fantastic, right? So lots of great and diverse examples here. So again, we want to encourage you guys to read through everybody else's response and see if you can pull it for your own practice. Great, moving food around, but then spitting it out, pulling food out of their mouth. Excellent. Yeah, gagging and vomiting maybe, best said because they aren't able to manage that food the way that they should. Great. Egg coker, poor chew, unsafe swallow. Excellent. These are all things that we see when we're seeing an oral motor issue. At a younger age, it could be dribbling milk. We're thinking a lot of even those older kids, but even from a young age, we could see that. Great, Kim, eating only food pouches. So going for what's a little bit easier. Excellent. So when we think about tools and strategies that we can use for an oral motor concern, here on the screen you see resistance bites, mouth massages, or a straw or open cup. Use your stamp tool again. What have you guys tried with some success in homes? Excellent. A lot of people using that straw and open cup to work on the coordination and strength. Resistance bites, lots of those. Excellent. I'm seeing probably the fewest stamps around mouth massages right now. So let's chat a little bit about mouth massages. So massaging different areas in the mouth, so that might be the cheeks, the lips, the gum, the jaw, ultimately can offer awareness of places that are less used and therefore have a little bit less awareness in them for kids. So we can also, in this suite, offer stimulation that encourages different oral movements as well. So this can advance to the use of electric toothbrushes or nook brushes that encourage different reflexes. I know I encourage a lot the use of the electric toothbrushes or other vibrating instruments to wake up different places of the mouth and increase oral responsiveness. So this can ultimately help with issues such as increasing tone or even range of motion. And I see, Catherine, you asked, what is a resistance bite exactly? So a resistance bite is kind of the general term, and it can span a range of instruments. So sometimes those are really specific therapy tools. They sell them in rings where they start with a lower resistance and then increase over time, so that a child that isn't chewing very well, you can get them to start biting on those simpler resistance or the lower resistance bites and get them to try and hold it down while you pull, and then the resistance can increase. If you don't use a therapy tool that's specific for that, sometimes it can just be a matter of getting children used to biting in the back of their mouth, sometimes in the front, depending on the issue, more challenging items. So first giving them something that's accessible and giving them slow increases while they practice that mouth movement. Great. So the very last challenge that we're going to talk about today is our medical challenge. And so medical feeding concerns, of course, relate to a child's medical diagnosis or their medical needs. So this is Trey. Those of you that tuned into Kim's part 1 talk on Tuesday might remember him. So we did an assessment with him together, and Trey has chronic lung disease, and he was put on a G-tube while he was still in the NICU because of concerns for weight gain. So when we went to the assessment, mom reported that the doctors had him on really strict volume restrictions and that they were not interested in feeding therapy. So they knew that his feeding was atypical, but they knew that it was going to be typical for him. And so we didn't create any feeding goals. Instead, we put in a DS provider. And so I went into the home and started working on some foundational feeding skills, so that once feeding was a priority, he would have a nice foundation, but he didn't need a feeding specialist right then. So in your practice, what are some medical concerns that you've seen that have impacted feeding time for families? Cleft palate, absolutely. Aspiration. Karen has seen low tone, embarrassment, tongue tie. Yeah, absolutely. Those micro preemies, Abby, absolutely. Yep. Lots of you guys have seen G-tubes in your practice. Vicky laryngeal Malaysia. Yeah, absolutely, Sherry. I had a little one that was on a ketogenic diet as well. Yeah, excellent. Failure to thrive. So you guys have seen a lot of challenging things in the home. Yeah, recovering from surgical repairs of lots of different things. We see that even sometimes with the cleft lip and palate, we see a regression after that repair. Absolutely. So we see a lot of reflux, G-tube. We could even, allergies, Carrie, I was just about to start talking about food allergies. So sometimes they're the more common food allergies. We see a lot of milk protein allergies in Virginia Beach. We've been seeing more of those, all the way up to FPIES, foreign opiate syndrome. Right, absolutely. So go ahead and check out your toolbox tips handout for a couple of things, but what I want to talk about specifically today, just briefly, are recognizing boundaries in the homes of families with children with medical concerns around feeding. So sometimes these can be the most challenging for us going in as a primary provider, because we're encountering situations that we might be completely unfamiliar with. And we might feel the limits of our experience and knowledge being tested more here than in any other area. So we always have to remember that the doctor and the medical team working with that family should be the only ones that are directing nutritional intake and medical recommendations. So when we consider strategies, I always suggest mom ask about the doctor's thoughts at their next appointment. So in some homes, parents will present me with the information, hey, we just saw the gastroenterologist. Do you want to look at kind of the recommendations that they made? And we'll work to formulate a plan based on the doctor's recommendations. Now, if me and the mom are talking about some things beforehand, then I'll encourage the mom, go ahead and ask your doctor when you're there next week, just so that we can ensure that all of the strategies we are putting in place does meet the medical priority in that home. And the other thing that I really want to talk about is how critical it is that we meet families where they are rather than where we think that they should be. So oftentimes children who are medically fragile and their parents have been exposed to a lot of trauma. Sometimes it might be a single traumatic event. Sometimes it's ongoing trauma from the things that they've experienced through birth in the NICU or other events that have happened. And as providers, we need to be so sensitive to what goals are realistic for them at this time in their journey. So sometimes as providers, we go into the home and we recognize, okay, these feeding goals aren't realistic based on what we're seeing. But sometimes as providers, we think to ourselves, oh, he's totally capable of doing that. I really think looking at how he's managing this food that he could go on to something more challenging. But always recognizing a family's boundaries and working with them really directly on working through the trauma that they've experienced and creating a plan that parents feel safe and comfortable with, even if the medical okay has been given. So the next thing that we're going to do today is check out a couple of case studies. So first we're going to look at David, and then we're going to look at Ellie. And while I'm reading these case studies to you guys, what I'd really like for you to be thinking about is what challenges you feel are present in the information that you'll hear. So it might just be one, it might be more than one. And after I'm done reading, we'll give you guys some time, and then Jeannie will put up a poll so that we can kind of see all the issues that you guys feel are present. So our first kid is David. He's 28 months old, and David's parents explained that their 28-month-old is a very picky eater. So he's continuing to prefer soft foods, and he will keep food in his mouth for extended periods of time. So sometimes they'll clean up from dinner, he's in the corner playing, and they find that 30 minutes later, he's still got some stuff pocketed in his cheek. Because he doesn't often eat well at meals, mom is continuing to nurse him on demand. So David is drinking his water and juice from a soft spout sippy cup, but he's only drinking milk from the breast at this time. Both parents conveyed that they would like him to stop grazing throughout the day and eat meals with his family. And mom reported that at this time, she's really ready to start weaning David from nursing. But even though the doctor has stated he doesn't have any concern for David's weight gain, mom doesn't feel right now that she can wean from nursing because of David's nutritional needs. So Jeannie's going to pull up a poll. And again, what we'd like you to do is just click and submit on the challenges that you feel are present. So behavioral, medical, sensory, or oral motor, what concerns are you seeing? All right. So the vast majority of you noted behavioral issues. Absolutely. So here we're definitely seeing the concurrent challenges that we discussed earlier, because we're seeing behavioral feeding challenges as well as another. So first, let's talk about the behavioral challenges that we're seeing. If we consider both David and his mom's behavior, we see that he's able to access liquids all day long. So from birth, he has had grazing tendencies with his liquids. So even though mom and dad are showing primary concern with his grazing during mealtime, if we think about it, we're noticing that he's actually learned to graze from an early age all the way through now. So that's definitely become a behavior of his. And sometimes that can affect his hunger cues and to know when to wait to eat and all of that, absolutely. Mom also has fears about his health. So that's caused a behavior in her to continue to nurse even though she doesn't want to participate in that anymore. So these are excellent behavioral observations. I noticed that a few of you had noted a medical concern, and sometimes that is something that we see in these children, but the doctor has said there's no concerns for his weight gain. He says that everything is actually good to go. So we're not seeing as much of a medical concern here like some of the things you guys had mentioned before when we see weight gain issues. So I noticed that sensory and oral motor challenges are almost equally chosen here by 45 of you guys. So let's talk about that for a minute. What we're noticing is that he prefers those soft foods, which I know a lot of us talked about during our sensory challenge, is a preference for purees, soft things, and that is absolutely something that we see in children with sensory concerns. But if we think about it a little bit more deeply, what we see is he's putting everything in his mouth that its parents give him. So they haven't expressed concerns that he doesn't want certain foods, but we see him doing things like leaving food in his mouth for an extended period of time. Sometimes 30 minutes later, they see that things have been pocketed in his cheek. And that can be a process that kids use to soften harder foods up to make it more accessible for them. So that can signify some potential muscle weaknesses or even coordination difficulties. And then the other thing that we notice is that he's got that soft spout sippy cup. So at 28 months old, he's still using the drinking receptacle that it has that immature suck swallow pattern. So he hasn't matured that yet. From breastfeeding to a soft spout sippy cup, it still has that similar tongue down posture. So with David, we weren't thinking of sensory concerns so much as we were seeing the oral motor symptoms, the oral motor concern symptoms and those behaviors. So now let's check out Ellie. So Ellie is 16 months old, and she has been fed primarily through her G-tube since it was put in place at 3 months old. The doctors did this because they were concerned that she wasn't gaining weight as she should. So at around 6 to 8 months of age, mom and dad were using that G-tube, but they started experimenting with purees and small foods because the doctor said that that was okay. But when she was 8 months old, she choked on a piece of bagel that was on her tray. And after that, she started to refuse all of her foods by mouth. So now at 16 months old, Ellie's parents are reporting that she gags if her parents put food on her tray, and she'll cry and turn her head away. She's recently started tolerating at least looking at and touching foods like Puffs or Cheerios if mom and dad put them on her tray. But if they try to introduce purees again and try and spoon feed her, she will start to scream. So mom and dad, they've been feeling really discouraged by that and don't want to continue to feed them. During messy play, mom and dad have been trying that. Ellie's not touching slimy textures, and if her parents try to encourage her to put her hand in and try it out, she'll flex her hands out and hold them out for her parents to clean immediately. Ellie is blocking her parents anytime they try to bring a spoon near her, and she's not interested in playing with spoons or even trying to bring them to her own mouth. So Jeannie's going to bring a poll up again. You're going to see the same choices as before, the 4 challenges that we talked about. And based on what you heard about Ellie, what are the challenges that you feel you're seeing in their home? All right, excellent. So with this one, we have another clear leader of behavioral issue. Absolutely, you guys pegged that immediately. So we know that Ellie has experienced a traumatic event, as have her parents watching her choke on that bagel. So she's now using some protective behaviors like blocking her mouth, refusing to let a spoon come near her, swatting things away, crying during mealtime, absolutely exhibiting some behaviors that could be worked on to help with that mealtime routine. And then, as many of you noted sensory concerns as you did behavior challenges, because of those things we talked about, not wanting her hands to be messy. I know some of you had mentioned in our sensory section how she will eat Cheerios and Puffs, those kind of rough, non-slimy textured things, but she doesn't want any of the pureed items. Absolutely. And then 28 of you noted that medical concern. Absolutely. So she does have a medical challenge, but she still is using that G-tube, and she's relying on it primarily to get all of her food from it. Otherwise, she would not be getting the food that she needs at her age. Absolutely. So I noticed several of you chose oral motor, and there's potential that perhaps an oral motor concern could present itself in the future if she's not coordinating her mouth and practicing with those skills. But as far as the case study goes, we didn't have any direct examples that tell us that there's a definitive oral motor issue present. Now, if you hopped in this house and worked with the family longer, you definitely might start to see some symptoms. All right, excellent job kind of analyzing this study so quickly. I know in the home, you'd probably spend a lot more time with it and ask a lot more questions. Right. So as our case study showed us today, working on feeding challenges can be very challenging for providers. So at what point do I take a step back as a developmental provider and say it's time for a feeding specialist to come in? But first, I want you all to take a quick second and put a stamp next to your discipline. We tried to think of as many as we can, and I know we probably missed even more. But if your discipline is listed here, if you're a physical therapist, nutritionist, service coordinator, go ahead and drop a stamp so we can kind of see what our audience looks like today. Great, lots of speech language pathologists, lots of service coordinators today, lots of developmental service providers. Excellent. So we've got a really diverse audience today, and I'm sure we've got some parents, some grandparents, system managers, lots of other people watching. And so I want you now to look at all these stamps. It's interesting that we don't have any feeding specialists or nutritionists here today. That actually plays perfectly into what I'm going to say next. I want you to think about all the stamps that you guys dropped on those strategies that I asked you to say that you tried earlier. And what this talk on Tuesday shows us all is that all providers are using helpful and appropriate tools when working with kids with feeding challenges without a feeding specialist required. So we've got occupational therapists, PTs, service coordinators who have tried giving parents suggestions, and this is great. In fact, research shows us that many feeding challenges are actually best addressed by a multidisciplinary team that's able to view concerns through the many different lenses of feeding. So in our Ellie example, if you think back, a feeding specialist could have been called to help address some of the many challenges the family's facing. But the well-rounded approach of a whole team would likely have addressed all of the needs that were present. However, If you reach a point in your practice where you feel your tools have been exhausted or you're uncomfortable with treatment and you feel you lack the knowledge that the family really needs, always, always consider what provider option might be the best substitute. So remain aware of your skill set and recognize when the strengths of your colleagues may better help a family achieve its goals. So as Kim noted back in part 1, no therapy is better than bad therapy. And as Stephanie added today, no feeding suggestion is better than a bad feeding suggestion. So when you all began this 2-part series on feeding, we prompted you with the question, and many of you were interested in, when do I seek a specialist when I'm in the home? And the answer to our question is actually very simple. So we encourage you to seek a specialist when you feel that the needs you see are beyond your capabilities. However, we really hope that through this process, with Kim, Stephanie, and I sharing information with you, that you feel more equipped today to address family needs that are within your scope of practice. All right. And so we want to open it up to see if there are any questions that you guys have that we didn't touch on today that you were kind of hoping to see, or if there's anything that we mentioned today that you're looking for clarification on. This is for Stephanie or I at the beginning or the end.
Thanks, Jessica. So if you guys do have questions for Jessica or Stephanie, please feel free to put those in chat. We will leave this open for a little while. And you will also notice that Lisa has put in chat to follow us on social media. That's where all of our activities are advertised, some great resources. So please be sure to follow us. And I'll be watching for just another minute for you if you want to add anything or add any question. Jessica, I will ask you to go while we're waiting. If you'll go to the last slide, we just want to remind everybody, especially those of you who might be new to our Talks on Tuesdays, that we will be taking a break for the summer and we will be back in September. We don't at this time yet have our topic, but it will be announced again on all of our avenues to get information out. So we hope that you'll plan to join us the first Tuesday in September when we will be back. I hope everybody takes good care, and thank you for joining us. Thanks, everybody. Bye-bye.